Hello, and welcome to Chagpar MD. I'm Dr. Anise Chagpar, and this week I have a very special guest. Dr. Tony Nguyen is a breast cancer surgeon in Florida. He happens to be a really good friend of mine, and I thought we would invite him to talk to us about something that you don't really hear a lot about, and that is what his experience was with his mother, who was diagnosed with ovarian cancer. I've always been intrigued by this whole concept of what it's like to be a caregiver and a physician and have a family member who goes through cancer. Now, in Tony's situation, there are a lot of key lessons that he learned, particularly with regards to genetics, but I'm going to let him tell you all about that. So, what do you say? Let's get started. Hi, Tony. How are you?
Hi, Anise. I'm great. How are you doing? Thanks for having me on.
I am doing great. Thank you so much for being here. So maybe we can start by you telling us the story of your mom.
Absolutely, absolutely. Well, maybe even a little bit of a backstory. It was essentially my first year in practice back in 2012 as a breast surgeon, a dedicated breast surgeon. When I'm seeing patients and talking to patients about cancer, and no one else in my family had been diagnosed with cancer. So although I felt like I knew enough to guide them through the journey, every patient's cancer is a journey for them. And one day I got the call from my mom, and she had some symptoms that a lot of people with ovarian cancer had. The symptoms of fullness, the pants don't fit as well anymore, and she was seeing her doctor and was getting worked up. And then a couple weeks later, she woke up and she said, I can't go to the bathroom. I can't seem to urinate. And I said, oh my gosh, and she was 61 at the time. So I said, Mom, you got to get to a doctor quickly. And she did. And the workup was done. And essentially, after a lot of imaging, found what seems to be a 15 centimeter mass in the pelvis. Both sides. It's one of her physicians told me he's never seen something like that before, where she had bilateral ovarian cancers that seemed to have met each other in the middle, so to speak, and obstructed her bowels and her ureters. And on further workup, her entire liver practically was studded with cancer, as well as most of her bone. Yeah, definitely dramatic in fashion. And, we had a lot of workup at her doctor's office and at a reputable cancer center. And essentially stage 4. A lot of what I figured out thereafter was, and I dealt with women's cancer before, but mainly related to the breast, not necessarily to the gynecologic arena. And 75% of women with ovarian cancer are stage 3 or stage 4. And essentially that's because there's not enough screening technology or guidelines out there that are good enough for ovarian cancer, unlike in the breast. And sort of to make a long story short, she was given sort of several months to live, but had heroic surgery and had a lot of chemotherapy, was on chemotherapy for a long, long time, and had multiple different regimens. And every year, cancer therapy gets better, gets more targeted, less side effects, less morbidity. And with all that technology and with all those advancements, she was actually able to survive for 7 years,
Wow.
despite the initial estimate of only 6 months, probably even less. So, I think I'm thankful for all those years, despite, life getting cut short. But I look at it from, I got 7 years instead of losing 6.5.
Yeah. So lesson number 1 is nobody can tell you how long you're going to live. And, therapies are continuing to get better all the time. And so there really is a role to really try to pursue medical management if that's what you want to do, and think about clinical trials. And so tell us more about some of the other lessons that you learned during her journey. One of the videos in this series, and I'll link it here for all of our listeners, we talked with Elena Ratner about ovarian cancer. And very similar to what you said, you know, she was talking about how this has for a long time been called the cancer that whispers, because, you know, the symptoms are really non-specific, you know, a little bit of fullness, you know, my pants don't fit right, and therefore oftentimes gets picked up really late. But she too talked about how, you know, now that they are genomic profiling these tumors and have novel therapies, the people are actually doing much better. But one of the things she also talked about was genetic testing. So tell us a little bit more about that with your mom.
Oh, absolutely. And let me do another backstory. Um, her family history was not well known. Much like a lot of our patients, as you know, when you go back 30 to 40 years and people passed away from a mass or a cancer, they weren't really given the full amount of information. Perhaps it was due to the culture back then, perhaps it was due to poor communication, but her mom had ovarian cancer, what I can best deduce. And really none of us knew until after my mom's diagnosis. So sort of almost the first lesson is know your family history.
Right.
Most people with cancers don't have a family history, but people that do have a family history have a significantly higher risk of developing that organ system failure, whether it be breast or ovarian. And nowadays, a lot of the cancer syndromes are linked. So first lesson is know your family history. I think that if we would have known that, I would have recommended that my mom would be seen and be treated much earlier than the time of diagnosis. The second lesson that you mentioned is genetic testing. It's still a really brand new field, despite having the human genome mapped out almost 20 years ago, more than 20 years ago. So nowadays we're able to test for certain cancer genes that have a pathologic mutation, and in those instances we can actually profile these patients, test them and test their family history, and or test their family members. And even more so, there are specific targeted treatments that are specific to people with genetic mutations and certain types of cancers like breast, ovarian, pancreatic, to name a few. So the precision medicine, not only in terms of targeted therapies, but due to genetic mutations, have come a long way since 2013 even. So in a lot of my patients with breast or even a history of ovarian cancer that had genetic testing even more than 5 years ago, I retest them because there's more genes, the panels are getting larger and larger, and the specifics are getting much better. Of note, when she did get her genetic testing in 2013, she was negative for the most common gene that affects a lot of women with breast and ovarian cancer, the BRCA1 and BRCA2 genes. They're the most well-known genes and the ones that cause the most amount of breast and ovarian cancer. She was tested and she was negative for that. So we took that as at face value. She got chemo and surgery and things like that, standard therapy. But with most people with metastatic cancer, eventually the chemo stops working if it's advanced enough. And so nowadays we use targeted therapies, and back in 2017 to 2018, that's when her chemo stopped working for her as well as it used to. So I just said, well, look, let me retest her, because I test a lot of patients. She was only tested for the BRCA1 and 2 gene. And lo and behold, she had a BRCA2 mutation that was found on a sort of a newer version of the test.
Wow.
And so because of that, she was eligible for one of the medications, essentially what we know now as a PARP inhibitor. And the PARP inhibitors gave her probably about 1.5 years extra length of life. If the PARP inhibitor was given much earlier, I think it would have extended her life a lot more, based on some of the recent trials that showed increased survival in patients with BRCA1 and BRCA2 mutations and ovarian cancer. So know your family history and get your genes tested if you have a high-risk cancer.
Yeah, and I think the other important point that you made And it's one that I'll link here to another video that we made on hereditary breast cancers, but the same principles apply. With this burgeoning of knowledge that we have about genetics and genetic testing, you know, if you test negative several years ago, you may test positive now, either for a different gene, because we're discovering more and more genetic mutations all the time, or even for the same gene with newer tests that are able to pick these things up, or for something like a large frame deletion, right? Where, you know, prior to 2008, we were really looking for what I like to call the spelling mistake in the book. But where we didn't find a spelling mistake, we weren't necessarily looking to see if entire pages had been ripped out. But we now have that ability as well. So, so talk to your doctor, especially if you have a family history, because the other thing that has changed most recently is, you know, guidelines. So at least for breast, now the American Society of Breast Surgeons is recommending genetic testing for just about everybody. And so now the NCCN has a little bit different guidelines, but it's certainly worth a conversation. So then she got tested and tested positive, thanks to you being very vigilant about retesting, and gets a PARP inhibitor. What happened next? I mean, did the rest of your family get tested?
Yes, so I got tested myself. We are actually a very small family. So I got tested myself because we just had a son, and so we wanted to know whether, you know, I was at risk. A lot of people, a lot of patients and doctors also see the BRCA mutations as a female gene, and that's a misconception, a big misconception. Males have it too, equally can have it. We don't have ovaries, and we are at a lower risk of developing breast cancer, even if we do have it. But there are other cancers that can happen based on BRCA, like prostate and pancreatic and melanoma. And so I got tested, and I'm negative. She has a very small family, so there was no other family members that were pertinent as far as testing is concerned. We have some offshoot cousins that I recommended that they get tested, and they will. And, you know, I agree with all your points that you made. In fact, a lot of doctors, even those doctors that work with cancer patients, quite frequently don't always retest people because the guidelines are extremely new. Testing used to be very, very expensive. Insurance tend to reject them, or, you know, patients had to pay out of pocket. So nowadays, testing is dirt cheap. $200 for a very, very large panel. And then oftentimes, even less than that, if you are, you know, you make under $100,000 a year, it's essentially almost free or covered completely by your insurance carrier. So to all the doctors taking care of cancer patients, and then to all the people with cancer or family members with cancer, you know, get genetic testing.
Yeah, I couldn't agree more. I think that the real cost differential has been a game changer. So what used to cost several $1,000s now is $250 even without insurance. So really, really helpful, and can have large implications. So Tony, when the one downside with genetic testing, which a lot of physicians may claim to be a barrier, is what do you do with all of the variants of uncertain significance? Have you seen that in your practice as you test more and more people? And what do you advise patients with regards to that?
Oh, absolutely. Great question. And a large area of, I don't want to say controversy, but uncertainties in people who try to do genetic testing. So yeah, if you have the BRCA, if you only test for the BRCA genes, they've been around for a long time. They've had large bodies of research dollars put into it. So the variance of uncertain significance is less in those genes. You know, we have lots of newer genes that were essentially just recently been studied. And so the way that genetic counselors and geneticists have explained it to me is that these newer genes are going to have a lot more variants of uncertain significance results. Um, there's panels now that are 80 to even 100 genes strong. So you're going to have, if you do one of these large panels, 90 to 95% of the time, you're going to have a gene that has a VUS or a variance of uncertain significance result. And I see that all the time. Whenever I do my genetic testing, almost always patients will have a gene or two that have a VUS result. So these VUS results, really how I describe it to patients is that we just need more data on this before we can categorize it. However, most of the results that eventually, when these genes get reclassified or more research is being done, they will eventually be negative. So we don't do anything different for them as far as their genetic mutation is concerned. We don't order more tests. We don't take out organs. We don't do more surgeries. We don't test their families based on the VUS results. Management will be based upon their personal and their family history only.
And so getting back to your mom's story, another thing that you mentioned was that, she went to a large academic or well-reputed cancer center. So for all of our viewers out there, how important is that? Or at least how important is it to get a second opinion? Or is it? Should you go to your local oncologist if you're comfortable with them? But when is it time to be seen at a larger center?
Excellent question. And I've been asked about this quite a bit. And I think for the more common cancers, I think that a really well-run practice, local community practice, can usually handle more common cancers. As cancers become more complex, I think it probably would be a good idea to get a second opinion. Now, for all of my patients, after I discuss with them clinical trial data, told them about my experience, I always tell them at the end, look, you're going to have a lot of questions. You're going to probably ask your friends and family. You're going to probably Google stuff. And if there's things that I'm telling you that you're not comfortable with, or even if you want a second opinion, I really recommend you go get a second opinion. It's great if another doctor confirms what I've explained to the patient or given the patient options. I'm not threatened by anybody because I can always learn from them. And these are patients' lives we're talking about. So in patients with advanced cancers, I definitely recommend a second opinion. I also recommend that patients and their family members ask the doctor, how much experience do you have with managing my cancer? Do you see a lot of these cancers? Have you managed a lot of these cancers this year? If the number is in the single digits, you just can't be well informed of management and algorithms enough to really give a great opinion. Now, I know a lot of patients live far from large academic centers, and transportation and access can be an issue, but even when they go for a second opinion, it's just an opinion. They can bring that opinion back to their local doctor and see if that doctor agrees and is able to treat that patient. Oftentimes these drugs and radiation, they're replicable to anywhere you want to go. Specific chemotherapy regimens are not isolated to large academic centers, but when to give it, how much to give it, other options, clinical trials, expertise. These are all things that I think would serve a patient well when they have a complex cancer or when they have an advanced cancer. And even patients with early cancers, maybe deemed not so serious. If you don't feel comfortable with something about your discussion with your doctor, I would go get a second opinion, and I strongly urge that.
Yeah, I think that's so critical. I mean, a lot of patients think, oh my God, am I going to hurt my daughter's feelings? Am I going to, is this really going to be upsetting? But I think for most really good docs, we're all used to either giving second opinions or having our patients go and get a second opinion. It's really important. It makes the patient feel better knowing that they get a confirmatory result. Or can look at other options. And so my last question is with regards to clinical trials, which is another reason to get a second opinion. If some clinical trials are not offered at your particular center and are offered at another center, that's that's a good reason to think about clinical trials. But Tony, what do you tell patients with regards to clinical trials? Did your mom participate in a clinical trial? Was there some trepidation about clinical trials in her case or in cases of patients that you treat? And how do you kind of get people over that hump?
Sure, absolutely. So clinical trials have multiple benefits to them for patients. The first is their patients are able to have access to the latest and greatest advances in either surgical techniques or medications or chemotherapy or targeted therapies that are well researched in the lab and are now probably in either phase 2 or phase 3 trials, which I think that they will at least have as much benefit, if not more, than the placebos or the controlled treatments that they're given. So I definitely agree with you in that clinical trials should be offered, should be discussed. Not every center is going to have every clinical trial available at their center. So if I think ask your physician that you're seeing, is there another clinical trial that they think would benefit you as a patient? I think that would be really, really helpful. As far as my mother, she had surgery first. She had then standard chemotherapy, and we then went to an academic center, and they basically said that everything was taken care of as a standard of care. There were a few clinical trials that we discussed that she would have benefited from, but they weren't really going to make a huge difference in her overall survival. And she was very, very comfortable with her doctor saying that, you do benefit from, would fit into a clinical trial, but, I don't think it would benefit you particular. So she was comfortable not being on a clinical trial. And then obviously from a humanism point of view, being in clinical trials helps the other patients down the road. We benefit today from such great advances in so many things due to clinical trials, due to the patients that have, given their time and their effort and their bodies to clinical trials. And clinical trials these days are very, very protected from harm. I'm on my local institution's IRB, Institutional Review Board. And so all the clinical trials are ran through the board to protect the patient from any undue harm. So I think that clinical trials are of great benefit, and they can actually be life-saving in many instances, especially for advanced or complex cancers.
Yeah, I mean, your mom's case is so apropos to so many things, and I think, the key lessons that I've kind of learned just listening to your story can be summed up in really 3 words: advocate for yourself. So when you have those symptoms that just don't feel right, you've got a little bit of bloating, a little bit of fullness, advocate for yourself. Go get it checked out. When you test negative, but you think, geez, there might be a family history, maybe I should get retested, particularly with everything that Tony has told us today, advocate for yourself, ask for that genetic testing. When you are seeing your doctor and you're not really sure about his experience, you might have a little bit more of a complicated situation, you're thinking about getting a second opinion, talk to him about it. Advocate for yourself. And finally, when there's clinical trials that might be a benefit for yourself, again, advocate for yourself. Ask about those clinical trials. Tony, thank you so much for being my guest here today on CHAGPAR MD. I hope all of you found this video helpful. I hope you will like, share, and subscribe. And if there are other topics you want us to cover, please let us know. We would be happy to oblige. Until next week, this is Dr. Anise CHAGPAR wishing you all a safe and healthy week.